A good impact. The programs help me a lot, especially because sometimes you're feeling down when you wake up in the morning and then you get a call from someone like which you can open up to and then talk about your feelings and yeah. How are you in general? I'm good. I would say I'm good because I get all the support I need. Because every time, like when I'm feeling down, I know I have that one person that I can that one person that I can call and tell that okay, I'm not okay because of one incident. Yeah, thank you. So this problem, how did it help you? It helped me with mostly, I'd say, emotions and then accepting the situation because sometimes it's hard to accept like that was like you're pregnant and then you're not working, like those kind of things, like generally in life. So it has helped me a lot with accepting my situation and this.
Can you tell the other moms out there about this program so that they can?
Um, I'd say, okay, whether you're having problems or you're not having problems, I would refer you to the program because like it's very helpful and it's very helpful. That's all I can say. Thank you.
Wow, wow, wow. What a powerful testimonial. Thank you so much. Good afternoon, good morning, good evening, everyone, and welcome to this important conversation about investing in maternal mental health in Africa. I'm Elizabeth Kasuja. I am the co-chair of the HBGI Lived Experience Council, and I'm really honored to be moderating today's discussion. Before we dive in, I want to acknowledge something significant. Today is 18th September, and it follows World Suicide Prevention Day. And as we gather today to discuss maternal mental health, I hope we are reminded that mental health is not a luxury, it is a necessity, especially for mothers who are building the next generation. So, our webinar today is titled Bringing Better Outcomes to Mothers in Africa, a new model for investing in maternal mental health. I come to this conversation from multiple perspectives. As a clinical psychology student in Uganda, as someone who received the Queen's Young Leaders Award for mental health advocacy, and as someone who understands both the donor landscape and the lived reality of mental health challenges across Africa. Today's conversation is not going to be just about programs. I believe our conversation today is about transforming how we invest in mental wealth as the foundation of thriving communities. I see people joining us. Welcome, welcome, welcome. It's really great to have you here today. And as we begin, I'd love for everyone to please introduce yourselves in the chat and please tell us your name, your organization, your country or your region, and your role or interest in the in the maternal mental health conversation. And remember, you can also add your questions into the Q&A tab that's at the top left corner of your screen. And while we are doing that, I'm going to introduce our incredible panel who will be speaking with us today. We have leaders from South Africa's Health Ministry. We have program implementers who are working directly with our mothers. And we have partnership experts who understand investment in outcomes-based programs. So as I mentioned, before we get into all that and the amazing meat of our webinar, I have a clinical psychology background, and I believe it's important for us to take a moment to center ourselves. So whether you are a potential funder, whether you are a healthcare provider, whether you are a mother or a mental health advocate, we are all here because we care deeply about maternal mental health. So we are going to practice what we call star breathing. It's a technique that's usually used in mental health programs to help ground and bring us into the here and now. So I'm going to invite us, close your eyes if you're comfortable, or if you're not comfortable with closing your eyes, just soften your gaze. For lack of a better way of explaining softening your gaze, it's just don't stare at something too intently. I'm going to request Caleb to please share the slide. There we are. So I'm going to be giving the instructions. We are going to breathe in for 4 counts. When I say breathe in, just breathe, and then I'll say hold and hold that breath, and then I'll say exhale and you release it, okay? So are we ready? This is going to take about 1 minute. So let's go. If you're comfortable, close your eyes. If you're not comfortable, just soften your gaze and let's go. Breathe in, hold, breathe out. Great. Breathe in, hold, breathe out. Breathe in. As you breathe, feel the back of the chair you're sitting on. Feel your feet on the ground. Hold. Imagine what a wonderful wonderful session you're going to have. Exhale, breathe out. Breathe in. Hold. Breathe out. And for the last count, I want you to really focus on breathe in. Focus on your feet on the ground, your butt on your chair. Orient yourself with where you are now and come fully into this session, ready to really engage. Breathe out. Now let's take one deep breath and return to the present moment because we are grounded, we are connected, and we are ready for this important conversation about transforming maternal mental health all across Africa. Our purpose today is really clear. We want to share the progress and learnings from the Mawanete pilot program in South Africa, and we hope to generate interest in investing in outcomes-based maternal mental health programs all across Africa. We are talking about crisis intervention, we are talking about building sustainable mental health systems, we are addressing individual symptoms and also addressing systems. And South Africa is just the pilot. This project, as you're going to hear from the speakers, is scalable, it's adaptable for different countries within the continent and beyond. So allow me to allow our lovely speakers to introduce themselves briefly before we go into the discussion of the webinar. I invite each of our speakers, starting with Anaki, followed by Imka, Zintle, and Stacy, to please kindly introduce yourselves briefly. Thank you.
Okay, thank you. Good afternoon, colleagues. I'm Anaki Mahwai, Deputy Director, Healthcare Programs in Limpopo, Waterberg District. And then I'm responsible for non-communicable diseases. It includes mental health and also we call it CCMDD. That's a program for stable patients. And then I'm also responsible for communicable diseases. That is the re-imaging and imaging diseases. And then I'm also responsible for nutrition services. And lastly, I'm doing health promotion. And then before I coordinated all these programs, I was also coordinating TB program for the district. Thank you.
Good day to you all. My name is Dr. MK Engelbrecht. I'm a medical practitioner by trade, but I've been in the public health field for about 5 years now. I am leading the team at Right to Care, a health-focused organization in South Africa, in our partnerships with the private sector, and we've had the incredible honor to implement this pilot program alongside HBGI as part of the Greater Community Health and Wellbeing Program in the Limpopo province. It's really lovely to be here and so great to see that there are so many of us who are willing to spend an hour of our time to think about how we can better invest in improved mental outcomes for mothers and their children. Thank you.
Thank you. So good afternoon, everyone. My name is Zintle Pile. I have a background in social work and public health as well. I am employed as a program coordinator, so I'm the one making sure that things happen on the ground level and people are receiving the services that they need. So thank you.
Thank you so much. I just want to honor our moderator today and our esteemed speakers, especially Mayor Aniki. Thank you for being here today. I think it's a really good show for all of us who are uniting for mothers and babies across this continent. My name's Stacey Ann Pillay. I always start with that. I come from a rural area. I'm the first tertiary graduate in my family. And I start with that because many of the communities and mothers that we serve on many of our programs that address maternal and child health issues come from these underserved communities. My background is in human resources and health professions education, and I'm very proud to be the partnerships and Performance Director for the Healthy Brains Global Initiative in Africa. Thank you.
Wow, what a powerful group of people we have here today. I'm so excited. So, without further ado, let me go into the questioning. Mayor Anaki, you've mentioned that you work daily at the district level, and at that level, I know policy meets reality. I know you're probably running mental health awareness campaigns right now, and that you track maternal mental health indicators monthly. Can you please share the district's priority around integrating mental health into maternal and child health, and also tell us a bit about what you're seeing on the ground that makes this urgent?
Okay, thank you very much. I think when I was introducing myself, I forgot to also give you my background. I am a nurse by profession. So yeah, there is no health without mental health. And it's true, we are prioritizing maternal and mental health in our district, in Limpopo as a whole. Firstly, with our policies, you can see they are not, we cannot separate the two. Like what we are using, we are having the annual performance plan where we are rated, we are measured on quarterly basis on our performance, and where on the annual performance plan, we have the mental health, the treated new, and then we also have the other indicators for maternal. Just that, as Stacey has indicated, the program manager is in another strategic meeting at the province. And then we are also having the district health information system. This is a system where on monthly basis, in fact, on daily basis, we are able to see if the two is really like maternal and mental. It's really like the program are running together. So, for example, you cannot see a pregnant woman and not screen that pregnant woman for mental health condition. That is why even in the patient folder, this is included. And before it was not like this. But now, because we are trying to really merge the two, it's included in even in the maternity register and also the card for the women. It's part of that because we are prioritizing the two. And it's not only that, we are also having, it's a new system. We call it RIBDA. It's a rapid information data assessment. We are all doing both. We are having maternal, like we check our antenatal before 20 weeks, and then also our antenatal after 20 weeks. Same with mental health, and then also checking if they are pregnant women are screened for mental health disorders. Yeah. Okay, the other thing, we are also having our mental health policy, the National Mental Health Policy Framework and Strat Plan for 2023 up to 2030. If you check in it, you can see where the two programs are together. There are priority programs in this the National Policy Framework, and pregnant women are one of the population that is like prioritized for mental health disorders. So indeed, this is a priority in our district, and not only in our district, in the whole of Limpopo. Thank you.
I love that. Thank you so much. The data you're tracking and the stories you're sharing, I think, are painting a clear picture of need. And we will come back to you, but I believe this context is exactly what informed the design of the program that you're here to discuss today. So Imka, I invite you, against this backdrop of need that Anaki has just described, you led a discovery process to create the Mawanete program. So can you please tell us about where the program started, the genesis of this program, and give us an overview of the Mawanete program?
Of course, thank you so much for this opportunity. And I think, Ma'aniki, what you really were able to demonstrate is that firstly, maternal health and mental health are connected. And as you said, there's no health without mental health. And I also just really want to take this opportunity to acknowledge both the district but also the province in Limpopo, how real changes are being made and implemented in the health system to make sure that these two are connected and they are intertwined, and no mother is seen without also, at least to whatever time is allowed, also keep the mother's mental health in consideration. So I really want to take this opportunity to build on what you've already shared by showing how we used community-led design to design a solution that can complement this work. Because even with great leadership and even with a dedicated workforce, not everything can be solved in the clinic. And I think that's one of the things that's so important to keep in mind, that a lot of the moms that are struggling, a lot of the people that are struggling are not necessarily in the clinic. Stigma, isolation, social pressures, these are the things that we heard about all the time in our design phase. And even when we started thinking about what is needed in the community, these things begin in homes, these things begin in communities, and then they end up in the clinics. So that's where our program really comes in. So it's very important that we keep in mind we did not design this to duplicate any of the services that the district is already offering, to duplicate any of the guidance that is in our guidelines and our policies and our frameworks, but it's to fill a critical gap, because we need to start in the community and we need to find the people who are at need, and some of them don't even know that they are at need because they don't have the language to articulate that they are in need, and actually bring them back into the health system. So when we started, we really started with a deep dive design phase, which was actually preset. A big part of our design was discovery. This was led by our partners at Matchboxology through a human-centered process, which was really great because we began by listening to moms, we listened to health workers, we listened to some of the policy implementers where we had opportunities to also engage, also community role players, police officers, CBO members. There were a whole lot of people from the community that we decided to speak to and to listen to. So we co-created a program that focuses on support, connection, and early intervention. So it's both promotive and it's preventive, and it's really, I think one of the key asks or the key challenges was, how can we make sure that this program focuses on building resilience before crisis happens, and then of course to also catch those in crisis and refer them onwards. Of course, it was very important with all of our programming at Right to Care. One of the biggest things is to make sure that it's aligned with the Department of Health priorities, and that it's also interlinked with some of the indicators that are important to the district and to other stakeholders in general. So things like antenatal visits, immunization visits, HIV and TB case finding, linkage to care and adherence, although not in the focus of this intervention, kept also coming in, because we know we're treating the mom as a whole. We're not treating only maternal health in a siloed approach. And then I think the last point about the genesis and why this is quite different for us as implementers as well, and which makes it really exciting, is its outcomes-based design. So I think this is what makes our approach powerful. I guess it makes it risky, but it also makes it powerful. And because it's a pilot, we are sharing the risk. But we asked mothers what matters most to them. And then we worked with the district and provincial stakeholders to define the impact they wanted to see on the ground. And from there, we were really given an incredible freedom by, as we did this in partnership with Anglo American as our funder, we were given this freedom and then also the guidance by the Healthy Brains Global Initiative to design an intervention that prioritizes these outcomes above everything else. So we are not funded for preset activities. I do not give Zinhle a list of things to do and she runs around the field, checks them off, and we submit that to HBGI. No, we actually are incentivized to adapt our intervention, sometimes weekly, sometimes daily, sometimes every 3 weeks. It really just depends on how it goes. But the point is that we need to reach the agreed outcomes above all, and we have the freedom to tailor, to change, to nudge, to do what we need in order to achieve those outcomes. So really from our side, it's been a really refreshing approach, and it was only because of the guidance of the HBGI team and the support from our funders that we actually have the liberty to implement a meaningful intervention while being held accountable for achieving these results that also matter to our stakeholders, both in the community, but also in the Department of Health at sub-district, district, and provincial level. Thank you.
Thank you so much, Imka, for sharing that. And you've mentioned something really important, that many of the challenges that mothers face do not actually start in the clinic, but actually in their homes and communities. And I've heard it say that this is a program for mothers, designed by mothers. Can you expand a bit more about that, please?
Yes, of course. So basically, how the program works is that we are enabling, so we have mother champions that are from the community. So our mother champions in the communities, they are all mothers. So they know what motherhood means, and they were identified to help mothers navigate the process of pregnancy, preparing for delivery, and after delivery. So what is really important that we found through the design phase is that emotional inquiry is not something that comes easily to the mothers that we are working with. So giving them the simple tools of thinking about, and I think also about grounding themselves, asking themselves, what is it that I'm feeling? Because you can only understand why you're feeling something when you know what you're feeling. And then giving them very, very practical tools and nudges on how to deal with that emotion. And that's acknowledging all emotions, both positive and negative, and just identifying them and dealing with them. So that's the first part of the intervention. The second part of the intervention is to also assist mothers to prepare something for the arrival of their baby. So we have cuddle boxes, which the mother champions help the moms make, which is just something practical when moms often feel overwhelmed, they don't know where to start, what to do, little things they can get for free that they can gather that help with communication, sensory stimulation, preparation for the arrival of the baby. And then we also have Mama Mookie. So Mama Mookie is our little virtual, or she's not virtual, she's in a book, but she helps a mom throughout the journey. She has tips and tricks for everything from how to know whether you're pregnant, how to tell your loved ones that you're pregnant, what to do when you have morning sickness, when your baby might be coming, all of those practical tips. And the important part is that the mother champions, as well as community healthcare workers and some members of community-based organizations, were all upskilled to use these tools, to actually use them in the community. But in addition to that, the healthcare providers within the facilities were also trained to use these materials to also deepen their emotional inquiry and to add on to those questions that are in the maternal antenatal record, because it's just to help facilitate that conversation in a slightly easier way that is more understandable. So those are the tools. And then the very important part of the mother champions is that they walk alongside the mothers throughout the journey. It doesn't matter where in your journey the mom enters the Mawanete program, she will be supported up to the point that she says, I am now okay. And even then, we'll check in again to make sure that she's still okay, because I can be okay today and be not okay tomorrow, and that's perfectly fine. And then we've layered all of that into, so we have an application-based monitoring and evaluation tool that also gives us as program managers feedback. So the mothers get sent repeated SMSs to inquire about their emotions. And if a mother, for example, has 3 consecutive negative emotions of a certain intensity, that flags the mother champion that this mom actually really needs help. So we do a physical check-in, make sure that the mother is okay. And then, of course, in all the sessions, we also just inquire, and if there's anything that needs flagging, we do have referrals. But I'm sure Zinhle will also get to a lot of this, so I don't want to get into too much detail. But it's really about enabling mothers to identify their emotions, to acknowledge them, and react to them. So yeah.
Thank you so much, Inka. The more I hear, the more I appreciate this program. And I really love that insight you shared about meeting mothers where they are in their communities, in their own language. And I think that is exactly what makes this program different. And Zintle, you see how this plays out every day because you work directly with the mothers enrolled in this program. So I invite you to please share with us, what does this program look like on the ground, Zintle? Can you share a specific story that will help us understand both the challenges that these mothers face and how the support you're providing actually changes outcomes?
Thank you, Elizabeth. So I'll start with the name Mawaniti, which means a true mother. So it is a name that reflects our vision of walking alongside mothers, supporting them, not just clinically, but emotionally from the moment they discover they are pregnant, even 6 months after post-delivery. So our program, as they mentioned earlier, we currently operate in 2 districts, which is Sekhukhune and Waterberg, which are high maternal and child health burden areas. Also, there's a team on the ground. We don't do this work on our own. There is a team that Doc mentioned. So at the heart of our program, we have our mother champions. They are lay workers from the very same communities where the program is implemented. They are mothers themselves, which makes the support relatable, empathetic, and deeply human to a pregnant woman. So a mother champion feels like your trusted friend who's walking beside you through this lifelong, most vulnerable journey. So what our mothers do, what our mother champions do at the ground level, they provide emotional support, practical guidance, referral to health and social services. So they continue supporting these mothers throughout their pregnancy journey while dealing with mental health challenges. That happens during pregnancy from the moment they discover that they are pregnant, post and 6 months post pregnancy. So that also comes with now the mother's own challenges, which I'll just give a glimpse or an idea of some of the challenges that these mothers have. So the number one would be stigma in our communities. Where we come from, where we offer these services, mental health is still heavily stigmatized. So many women hesitate to open up about depression, anxiety, or trauma, and fearing judgment and reaction. So our mother champions work hard to break the stigma, but it also remains one of the barriers. And we also have, GBV, right? Pregnant or not, some women, if not most, do experience some form of GBV. So we've encountered heart-wrenching cases of women pregnant as a result of sexual violence, including teenagers in that group. So these young mothers are at a high risk of depression, suicide attempts, and social isolation. So we've had to build strong referral system with the DOH. I think that's why Mayor Aniki is also here. She's part of the support structure and somebody who actually appreciates this program. So these services provided by the DOH in collaboration with us as Right to Care is to offer psychosocial support and services, and also to get them to the next level care of service, because remember, we do have lay workers at the ground level. So Another, a surprising one yet frequent challenge is the lack of proper identification document, believe it or not. So without IDs, many of these mothers cannot access the social grants. So a social grant is critical because most of these mothers aren't financially stable or do end up being a single parent. So I do have one story of which is very touching to me, of a 16-year-old mother who was, I think, 3 days post-delivery. She went to the SASSA offices to apply for a grant, obviously. And tragically, the baby passed away while she waited in the queue. So this was a moment that underscored the agency of fragility of the work that we do. So despite our efforts, we've still seen stillbirths, miscarriages, infant death just days after birth. So each loss leaves a mark, not just on the mother, but also on the mother champions. So the gap we're trying to bridge, or we want to get them at a point where they can still be assisted in terms of the emotional burden, in terms of their traumas. So a recent one that a case that I've been attending to as well was of a teenage mother who fell pregnant through sexual assault. She had been struggling with depression. She had attempted suicide, and ultimately during birth, she lost the baby. So I guess with the collaboration with the DOH, we were able to refer her to the best care in terms of the emotional side and the mental part of her care. So in the face of these challenges, our approach is compassion, collaboration, and continuity. So our mother champions are people that are trained to offer emotional first aid and trauma-informed care. And as I mentioned earlier, we work closely with the clinics, with social workers, as well as the district service level to ensure continued care for these mothers. So we don't stop to support a delivery. I'll reiterate, we follow up with these mothers for 6 months post delivery. So through these efforts, we've been able to build trust and improve outcomes, not just for the mothers, but for the babies and the families as well. So when a mother champion steps into a mother's home, right, she brings more than health information. She brings dignity, she brings understanding and hope, which is to empower these mothers. So yeah, I think I'll stop here and wait for your questions.
Thank you so much for sharing that, Zinhle. And I'm so sorry to hear about the loss of that baby. May their soul rest in peace, which really speaks to the importance of your work. And you've painted a picture of mother champions working through stigma to support other mothers through what can be the most vulnerable 15 months of their lives, because from pregnancy discovery through the 6 months postpartum, that's about 15 months. And that's intensive personalized support addressing barriers that would keep women from seeking help. So either Zinhle or Stacey, for our funders who are listening and who are thinking about what is the cost per beneficiary, that's quite a long time that you're supporting them. What does it actually cost to provide this kind of comprehensive support that reaches a mother from the moment she discovers that she's pregnant through those super important first 6 months postpartum?
So that's actually a good question. I think Stacey will cover in her presentation as well. That's covered with what she has to say and share.
Okay, thank you. So Stacey, I invite you to answer that question as you come in, please.
Thank you so much. To answer the question, it costs $114 per mother baby pair. We know the fertility rate in areas like Limpopo is that a mother can have up to 3 children, and most households in across South Africa really have about between 3 to 4 children in the household. So when we talk about a mommy and baby pair, because we support a mother, as Zinhle has outlined, but we know this has a greater impact on the household. So that is, in short, the question. But I actually want to come back, if you allow our moderator, to Me Aniki, because Me Vikti, our director for maternal and child health, could not be here today. She was kept at another meeting. But there's a very interesting problem that we face across our continent, which is around adolescent pregnancy.
And even in our small pilot, we're seeing up to 20% of the mothers that we support being in the ages 10 to 14 and up to 19. So adolescent mothers are the majority of people who are being supported in some of these areas through Zintle's program, some of them being very young. The last mother that Zintle highlighted being very young, and really there being a lot of risks associated not only with the pregnancy, but with continuity of care for the baby. And Me Aniki and her colleague Me Vicky are really very powerful because they've come together to embody this idea of integrating mental health into maternal and childcare pathways. And I really want to appreciate that. But even with all the political will and our very progressive policies that we have in our country here in South Africa and in many African countries, actually, there's still a big gap. And the gap is that we really, when it comes to mental health, we are often very deficit focused. So we talk about the number screened, we talk about the number put off treatment. We're not really focused on what does a beautiful, thriving mother and baby look like. And that's what our outcomes program really enables us to do. Because when we sat down with mothers, they told us these things, that because they don't know what to expect during pregnancy and delivery, they're very vulnerable to emotional and mental shifts. And so part of their desired outcome is for them to feel prepared, to know what's happening in their body, to be prepared for delivery, and to also be wanting to go to antenatal care, because we have a problem of late bookers across our continent as well. And we can see how these two factors around adolescent pregnancy, around maternal and child health actually come to a head in the mental well-being of these young mothers, especially. And some of the stories that Zinhle is sharing today. So this is not just about a mother. This is also about their baby. This is also about the children in the household. We hear stories of people, neighbors hearing the mother shouting and admonishing her at the children because of sheer frustration, not being able to articulate how she feels or getting any support. And so our program is anchored in the outcomes that matter the most to the mothers, and they get a say. So they report to us through a self-survey through SMS about whether they are achieving the outcomes that matter to them. Are they feeling, knowing what's going through their body and feeling prepared for their pregnancy, birth, and when the baby arrives? Do they want to go to antenatal? Do they have someone who asks them how they are? And do they have someone to turn to when they are not coping and they are not okay? Are they feeling connected to their baby? Are they feeling happy to be a mother? We go to these mothers in some of the most vulnerable times in their lives, as you shared, in the postnatal period, when a lot of them are not returning to clinic after delivering in a hospital, so their baby can get immunized and get continuity of care to increase their chance of survival and being able to thrive and meet their early childhood milestones. So yes, I can articulate the cost, but as of now, our program is actually very new. We're seeing some very good outcomes coming out of it, and even some movement in some of the impact indicators like early antenatal care, but we're not there yet because it's so new, because it's promotive in nature. And so what we do hope that we will find is these kind of very real impacts on population level, but also in terms of the mothers themselves, that they will be engendered with agency as their mental health improves, that they will be able to take better decisions for themselves and their children. And that's where it really changes things. And the focus on outcomes is really important because it means that the right to care team can be really responsive to what the system needs. Me Aniki and her team often brief us and give us guidance to what the beneficiaries are saying and need. So of recent, we actually have moved some of this into the cultural space. So
partnering with traditional authorities to get to mothers that may be feeling very isolated and not confident to go to the clinic or even to ask for help. Zinhle's team has done an amazing job. And because it is responsive that way, and because we performance management and look at this data all the time, we're able to use every rand for the maximum benefit, reaching more mothers for less money. We also know in Africa, we're never going to come to a point where we have amazing clinical psychologists like you, Elizabeth, in all of our sub-districts or even our municipal wards. We know that's not the reality for us. We live in a low-income area. But the truth is, on our program, we found that most of the mothers with very basic, low-resource support, like getting an ID, help to get a grant, being connected to services, being referred to the social worker, being helped to return to school after they fall pregnant and have a baby. Those very basic support services, which are very low cost, are able to really make the difference in someone's life. Thank you, Elizabeth.
Thank you so much, Stacey. I'm just amazed that the program is using only $114 to reach the mother and the child. As someone with a philanthropic background, that just really blows my mind. And I know you've made the case for it, but if you could give 3 key points, a bit more high level of what makes this program a good investment for our funders that are listening.
I think the first point is that because it's promotive in nature, it can really focus on low resource shifts that we can make for these mothers that make a huge difference in their lives. So it becomes very affordable. Because it's outcomes focused, it can really be very responsive and use every rand or dollar exactly where it's needed to get the impact we want. There's no time wasted. As Imka said, sometimes every day we adapt to what the mothers need and what the system needs. The third is a very important element. We really leverage off the strengths in our ecosystem. So partnering with the Department of Health is one. This program is truly integrated into the health system. In fact, the referral system is a very big point of leverage for the program, but also embedded in the strengths of these communities. So in one community that has a training vocational college, we leverage off a lot of programs that run for young people around substance abuse and other things, so we can get to the mothers. In another area, there's nothing. There's not even a church, but there is an ECD center that we're partnering with so that we can support the mothers who are not yet confident to be going to the clinic. Zinhle's Mother Champions work together with other lay health workers like community health workers and youth mentor mothers to be able to get to these mothers. And I see a lot of people who are involved in the health system or in training in the health system on the call. And I really want to say that this program takes a different approach to capability building, because we believe that, and a lot of health workers share this with us, they just don't have the words, they don't have the tools to be able to do emotional inquiry with their patients and with their clients. So it really, the third point would be it is integrated, and that means it leverages off the strengths in communities and the health system. Thank you.
Wow, thank you so much, Stacey. I'm quite fired up. I hope this is how we feel in this room. And to our participants here today, I encourage you to please post your questions in the chat. Our presenters will be able to respond to them right after this. So I know cost effectiveness is really important, but scalability is equally important. So this is my final question for all of our presenters. This pilot is in South Africa, but maternal mental health challenges actually exist all across Africa and beyond. So can you please tell us, and I'd request each of you to respond because you're coming in different capacities. starting with Ma Anarchy, because at the government level, we know that's really important before we trickle down to the community. How adaptable is this model? Could this model be implemented in a different context? And do you believe it would work in other countries? Over to you, Ma Anarchy.
Okay, thank you, Elizabeth. I wish this program can be rolled out, especially for us as Waterberg. I just wish we can roll out this program to other areas. For example, where we are at the district office, we are next to a sub-district called Mudimolle. Yesterday, I was busy there auditing the facility. There's a lot of 14 years that are pregnant. I managed to interview one. That girl was an orphan, staying with the brother who is 23, not working, and the father is married to another woman. So you can imagine a 14-year-old. When I checked with her, the guy who pregnant is only 17. So you can imagine the situation. Really, programs like this, I wish it was just all over the district, because we are experiencing a lot of challenges. And where this is, it's like the areas where Right to Care is supporting DOH, we can see the improvement there. And I wish this could be rolled out to other areas because of the impact and the type of the society we are living in, and the type of challenges we are experiencing in our communities, because we are having a lot of the 10 to the 19s that get pregnant, as I was indicating to you, one that I managed to interview. So this is a program that will really assist us a lot. That is why I'm pleading if it can be rolled out to other areas. Thank you very much.
Thank you so much, Ma Anarchy. Let's hear from you, Zintle, and then Imka, and then Stacy.
Thank you, Elizabeth. So the program is in need, and I feel like I'll make an example with, there's a clinic in Waterberg, Tabazimbi, where we work at. A lot of people from the township areas would rather travel all the way to Rihorogile just to get the experience of having a mother champion and get better services. So imagine if we had mother champions in those clinics that are closest to home. So there is a need. It's the capacity that's needed more. Thank you.
Thank you. Imka, please go ahead.
Thank you so much, Elizabeth. And maybe back to thinking around how scalable it is. I think because we started with what matters most to the mothers. Determine in the area where you're working what matters the most to those mothers, and then you kind of pivot the intervention around that and ensure that you achieve those, but you use the scaffolding of everything that was created, the lessons learned, the mistakes made, and you pivot it to achieve those outcomes. It can definitely be done. And that was the whole vision that HPGI had right from the beginning, as well as our funders, is something that works in our context, but that can easily also work in another context. We are currently in conversation, to hopefully see if through our branch, or our, what do we call it, Right to Care Malawi, to see if there's any way that we can perhaps work there as well. But we really encourage any people reaching out, anybody wanting more information. We will gladly share the information. We'll gladly share the mistakes that we made so that you don't make them as well. But truly, I believe that even comparing some of our more urban facilities, for example, the one in the town that Zinhle was just talking about, Tabazimbi, and comparing it to more of the rural areas areas, we already had to like slightly pivot within the program, and it was possible, and it has shown us that we can achieve those outcomes.
Stacey?
I have a very quick answer. The intention was that it would always scale, that it was built in a way that it could be culturally resonant if it was embedded in that context, that it would always take the integrated view and always focus on the outcomes that matter the most to mothers. So like Imka say, you just can't get it wrong if you do that. But there's definitely what personally I love about the outcomes-based contracting process is the process to define the outcome for the paid results actually makes you mindful of all the things that could go wrong and what is the best way to do things to make sure that it can work in your locale. There's elements of the program that are collateral that can be embedded. There's elements of the program that can be localized and run, but definitely the outcomes gives it its exponential edge and allows it to make some big impacts, not only for mothers, but also for the system.
Thank you, Stacey. Thank you. Do we have any questions from the audience after hearing all those, all that sharing? I feel like my mind is full, my heart is full. I'm really curious, but I'd like to hear from our audience. Let's have the questions from Caleb. Please share.
Thank you so much, Elizabeth. We actually have some questions that have come in. For one is for Anarchy, come in, and the question that's coming in is from an advocacy perspective, which advocacy arguments work best to convince health authorities that improving maternal mental health also strengthens key indicators like maternal morbidity and mortality? And we have two more after that, but I don't know. Let me just read the other two, and then Mayanaki, you can just hold on to that one. There's one, and that question is from Naomi. The other question is from Lena, which is, what practical things can I do as an individual to support moms or friends of moms or friends who are moms who may be facing mental health challenges, given that maternal mental health is not openly discussed in many African contexts? And the third question we have from Marion states, number one, are pregnant women identified as being at high risk for depression or other pre-existing mental health conditions prior to receiving care through the initiative? The second question on that one is there a method in place to evaluate the effectiveness of the initiative by comparing outcomes between women who received care and those who did not? So I think, Mayanaki, do you want to take the first one, and I can read it again for you in case you wouldn't want me to.
Okay. Can you please repeat the question?
Sure.
I didn't get. Yeah.
Sure. So the question from Naomi is, from an advocacy perspective, which advocacy arguments work best to convince health authorities that improving maternal mental health also strengthens key indicators like maternal morbidity and mortality?
Okay. Thank you very much for the question. I think what can be used for advocacy, like in Waterberg, we are having these two areas where Right to Care is supporting us, Mapila and Rohorogile. And we are able to, we can use like the outcome that we are seeing in the two areas as sort of an advocacy. Like if we had something like this all over the district, I think even our outcome indicators on maternal and both mental, they will really improve. I think what is happening in the two areas can serve as an advocacy for the program. Thanks.
Excellent. Now for the second question from Lena, I can just repeat it again. What practical things can I do as an individual to support moms or friends who are moms who may be facing mental health challenges, given that maternal mental health is not openly discussed in many African contexts? I don't know which one of our team would like to take that on.
Thank you, Caleb. I'll take that. So,
Wonderful.
what you can help a pregnant woman, you just need to be there. They don't need anything financial. Your presence counts. And for a lot of people who always look externally and forget internally. So once you acknowledge the support you have internally, that's number one, you've passed it. Number two, when Elizabeth, as the psychologist, started, this breathing techniques that we teach our mothers as well. And they do help a lot. But so I think in general, let me just cover it up. Reach out, accept help, and be there for those mothers. They don't need, it's no longer about finances, but having that friend. And that's what we are trying to do with the Mother Champions as well. Somebody to be there emotionally, who's very empathetic and who's very understanding. I hope I answered that question correctly. Thank you.
Thank you so much for that. And now to the third question from Marion. I'll just repeat it again. Are pregnant women identified as being at high risk for depression or other pre-existing mental health conditions prior to receiving care through the initiative? Second, in that one, is there a method in place to evaluate the effectiveness of the initiative by comparing outcomes between women who received care and those who did not?
All right. Thank you so much for that question, Marion. So I think maybe to start with the first one, the program was purposefully designed to not be deficit focused. So we do not screen, identify, and then exclude well mothers. We offer the program to all mothers that enter antenatal care in those selected facilities that we are supporting, all mothers that are found in the community to be pregnant or to need support. So it is both for what we would call well and not quite so well mothers. So we include everybody. And this is really because it is really promotive and preventative, and it's aimed to build resilience and coping strategies before crises actually arise. Of course, built into that, we have the referral systems, we have the flagging system to make sure that the mothers are referred to appropriate onward care where needed. And that's where the support from the district health services is so incredible. But we have also partnered with Bimbo, which is a mobile app CBT, like a phone application that offers cognitive behavioral therapy to the mothers that require help. And that's usually just because the health system is quite strained, so the waiting time for the referral is quite long. So it offers some support, slightly more advanced to the support that the Mother Champions can give to those mothers in need. The second part, whether or not to do a randomized control trial, was a big discussion point in our earlier project board meetings. We eventually decided against it. We're not against the idea. It's just we needed to balance the importance of making sure that the pilot has the best chance to succeed. And what we are currently looking at is we're looking at 4 DHIS indicators, which is the District Health Information System in South Africa, and we're comparing year-on-year data for 4 impact indicators, comparing them for the same facilities year-on-year. What we're also trying to still figure out is whether it would be possible to do same year comparisons for those indicators for similar facilities in the same district or sub-district, so similar profiles, etc. And then we're also really interested in actually looking at it from a different lens, where we look at the promotive impact and the cost benefit of preventing maternal and mental health deficits. So we are currently looking at whether when we do a second iteration, whether we also include a more standardized wellness analysis, for example, the wellbees, where we can then make our intervention more directly comparable to some other interventions, to see the effectiveness, but then also to do some cost benefit analyses to see to display the impact.
Thank you so much. And thank you, Caleb. Is that all?
I'm seeing a few more questions, but I'm seeing since we might be over time, Stacey has
Yeah.
also shared her email. I've shared my email as well. Please
Okay.
feel free to just reach out to us directly if you wanted to discuss this a little
That's
bit further.
great.
Thank you so much, Elizabeth.
Thank you. And thank you all for your engagement. I see we're a little bit over our time, but I hope it has been worth it for you. As we wrap up, allow me to highlight 3 key takeaways. First, this is not just about South Africa because maternal mental health challenges exist all across Africa, but so does the infrastructure and wisdom with which to address them. Second, this investment model works $114, $114 only for a whole 15 months of support for both the mother and the baby. The program is designed by Mothers for Mothers and it is integrated with existing health systems. Third, the time to act is now. The best time to plant a tree was 10 years ago. The second best time to plant a tree is today. So the time to act is now. Go out and act. For funders and investors that are listening, Stacey and the HBGI team are ready to discuss how this model could work within your respective focus areas. For implementers and health system leaders, this model is actually designed to complement and strengthen existing maternal mental health services. And for our advocates and community leaders who are here, please know that your voices matter in scaling solutions that work for our communities. I request that we close this as we open, which is with intention. So I'm going to invite you to bring your attention back to your body. First of all, we hold on to stress that you might not always recognize. So wiggle your body, shake, shake. Shake out your hands, shake your head, shake your hair. Dance a little bit in your chair. Next, bring your shoulders to your ears and release and let out a big exhale like this. Like that. Do it about 5 times. I hope you're feeling that tension you hadn't realized actually leaving your body. And then take a deep breath with me. Breathe in the possibility of transformed maternal mental health across Africa. Exhale. Breathe in again. Hold that vision. Hold. Exhale, thinking of your own commitment to making this vision a reality. Remember that the mothers and the babies whose lives will be transformed by the conversations that are going to happen after this webinar are counting on each and every one of us to act. So as we close, I really want to say thank you to our incredible speakers of the day. I want to say thank you to HBGI for convening this conversation. And I want to thank each of you here today for investing your time in maternal mental health. I hope you take this conversation and it continues in your networks, in your organizations, and in your communities. Thank you so much and stay well, everyone. Thank you. Bye-bye. Thank you.
Bye.